Hello and welcome to Pulmonology Read Aloud. Today we are discussing the first of its kind joint guideline by the American College of Rheumatology and the American College of Chest Physicians, which was published in August 2024. I already have a video about the joint statement on management of systemic autoimmune rheumatic disease related ILD, and this video is about screening and monitoring for ILD in patients with specific SARDs like rheumatoid arthritis and systemic sclerosis. We here have a roadmap on when to screen and how to monitor, and this has been developed through a systematic literature review with PICO questions asked to a voting panel. This guideline explicitly has advised against the use of certain diagnostic modality and has conditionally recommended most of the statements that they have. So while we don't have strong recommendations, it does outline how monitoring frequencies can be based on individual risk factors and how we can look out for disease progression. So let's get started and read this together. So, before we divulge into the details of this paper, it's important to understand why this guideline or this paper matters. Now, this is an excellent way of bridging the gap between a rheumatologist and a pulmonologist. And this matters because ILD is a leading cause of death and morbidity for patients with systemic autoimmune rheumatic diseases. And it is also specifically the greatest cause of mortality for patients with systemic sclerosis and a prime driver of excess mortality in diseases like rheumatoid arthritis. So, bridging this gap is now a necessity and a clinical mandate. This guideline addresses how patients with SARDs are at risk for developing ILD in general and how specific entities need to be monitored very carefully. Because, for example, a patient with systemic sclerosis, for that patient, more than 50% of such patients will have ILD as its leading cause of death and hospitalization. So it really matters on how you screen them and how you monitor them. So, what are we talking about here? Are we talking about all the SARDs? We are not. This guideline talks about the big five of systemic autoimmune rheumatic diseases, which includes rheumatoid arthritis, systemic sclerosis, inflammatory myopathies, mixed connective tissue disease, and Sjogren's disease. And here, though they have not talked about the other, because there is a relatively reduced risk of interstitial lung disease and other rheumatic diseases, we also have to be careful in individually monitoring patients with all other rheumatic diseases for lung involvement. It identifies these high risk profiles and these patients with these diseases who have a higher risk of lung involvement. So the database searches were mostly for these diseases, hence recommendations have been made for these. So let's see how and when we should screen and monitor patients with these diseases. The key concept here is that not all patients with SARD require a screening, but patients amongst the big five definitely should be screened. It also lays emphasis on the fact that given the risk based on every individual patient, we have to follow a risk-based approach. Why can't you run an HRCT on every newly diagnosed SARD patient? Because the risk may change. So, the key concept that has been stressed here is that do not use a blanket screening. You test, you screen the patient based on his risk. You should avoid aggressive testing in asymptomatic patients with the low pretest probability because you will have a risk of higher false positives. But you must definitely screen patients who follow in the high risk category. So, for screening recommendations, they have taken critical outcomes like would a screening change the disease related outcome like progression? Would my screening change the events or the adverse events? And for monitoring recommendations, again, they look at disease related outcomes. They look at responsiveness to change of a test as a surrogate. So, this strategy requires precise risk stratification amongst the big five SARDs: rheumatoid arthritis, systemic sclerosis, idiopathic inflammatory myopathies, mixed connective tissue disease, and Sjogren's syndrome. They have not made any recommendations on education, monitoring of oxygen saturation, how to test whether your patient requires supplemental oxygen, or any other outcomes like using questionnaires like a SGRQ questionnaire or any dyspnea index. So they haven't gone into depths of those, but they can definitely be used as our supplementary aid during monitoring of these patients. So, who is at risk? The guideline says do not do blanket screening, but the paper also mentions that do screen people in the big five diseases. So, it has been recognized that all of these big five diseases confer an increased risk of ILD development compared to the general population. But since the risk profiles vary dramatically, for them as well, you will have different criteria to understand how much you need to screen them. Do autoantibodies affect the screening modality for all? Is smoking the common variant, or do we look at phenotype? That has been clarified. So, for instance, when you're looking at patients with systemic sclerosis, those patients who have an anti SCL70 positivity or an ANA antibody with nucleolar pattern, they must be screened because they have a high risk of lung involvement as ILD. Those patients who have a diffuse cutaneous subtype, who are males or are African Americans, need to be screened. And patients within the first 5 to 7 years of onset of the disease and the ones with elevated acute phase reactants must be screened. So, the primary indicators will be an early diffuse disease, which means that patient may have rapid skin hardening, patient may have systemic features of systemic sclerosis, which should be in the earlier phase. You must go ahead and screen them. But do we only screen diffuse systemic sclerosis? They say that there are people with limited subcutaneous systemic sclerosis who can also have an ILD, but it has been seen that patients who have a limited cutaneous systemic sclerosis usually have milder and more stable ILD compared to diffuse. So, patients with diffuse will definitely merit screening. When you talk about rheumatoid arthritis, the risk correlates with being older at disease onset. The risk also correlates with being a male and being a smoker and having a higher BMI. So, smoker males older age of onset of rheumatoid arthritis will have higher propensity for lung involvement as ILD, and also those who have a higher titer of rheumatoid factor and a higher titer of anti-CCP. We've often seen that pulmonologists are really interested in looking at the anti-CCP levels and the RA levels, while a rheumatologist may see them as a marker for probably something else and not for a marker of a lung involvement, while we are correlating it with the severity of the disease. So, this gap has been bridged, and now, if your patient has a higher titer of anti CCP and RA factor, it means you must screen him for lung involvement because they might have a higher disease. Now, if you talk about rheumatoid arthritis as such, then only 3 to 5% people with rheumatoid arthritis may have a progressive ILD, according to the sources that have been reviewed in this literature. But they also have shown that a large proportion of RA patients may have an asymptomatic or a stable disease which may be undetected unless you screen. So, screen all RA patients with high titers, screen all RA patients who are smokers with older onset and who have high BMI or are males. Coming to idiopathic inflammatory myopathy, now here again specific autoantibodies such as anti-synthase, the Jo1, PL7, PL12 antibodies, anti-MDA5 antibody, and anti-Rho52 antibody positivity have a higher risk of ILD. If the patient has clinical signs like mechanics hands or ulcerating lesions, again they are at high risk and they should be screened. When we come to mixed connective tissue diseases, here patients having Raynaud phenomenon, dysphagia, or other diseases, the features like systemic sclerosis, they should definitely be screened. They are at high risk. And when we talk about Sjogren's syndrome, patients who are older in age, who have lymphopenia, who are positive for anti-Rho52 and ANA antibody, and also there have been reports of severe dental caries being associated with a higher risk of ILD. So, screening has to be tailored to an individual patient, recognizing the need of a shared decision making between the rheumatologist and the pulmonologist. And although most people with systemic sclerosis or IIMs may be asymptomatic, and for many, it may not be important for screening. Those where you find these risk factors, you should screen them. But do we only screen those with these risk factors? Again, the panel says that's a preference. For if you want to identify ILD early, you should screen the ones with risk factors, but you may not limit yourself to just these risk factors if there are symptoms, because there may be subclinical disease that may be undetected. Now, coming to the golden rules of screening, and remember, these are all conditional recommendations because the data is of less certainty. The evidence is not very clear, but it's a good indicator which can guide us on how to go about. So, the golden rule is that when you are screening, pulmonary function test and high resolution CT scan should be paired. There should be a concurrent use of HRCT and PFT rather than either alone. And they should be used in tandem because they provide complementary data. Now, when you are doing a pulmonary function test, they have stressed that you should do spirometry, you should check the DLCO, and if possible, you should also do the lung volumes. And when you are doing an HRCT, you should specifically ask for a high resolution CT over a standard CT. And you should not use a chest X ray as a surrogate for a CT because a CT will have a higher sensitivity. So, combined testing is helping us with an architectural map given by the HRCT, which is 100% nearly sensitive when the disease extent is above 20%, and a spirometry plus diffusion can measure the physiology for that damage. Would a clinical exam help us? It may help us, but that's not where you stop because If you look out for just a dry cough, it would be only 15% sensitive for detecting an ILD. And if you're looking for Velcro crackles with your stethoscope, they could only be 69% sensitive. So clinical signs here can sometimes fail because patient may have other features. For them, the prominent symptom may be just a joint pain or a fatigue, which can mask the decline in his cardiopulmonary capacity. When you're talking about patients with RA, they may just talk about their joint pain and agony and may not notice the breathlessness because they are hardly moving. So, do not use either alone, but rather use them in combination. They have recommended strongly against using a chest x ray, which has a low sensitivity of 58 to 64%, using only a 6-minute walk test or 6-minute walk distance for screening, because then again they may have arthritis, using bronchoscopy routinely for screening, or using surgical lung biopsy for screening because of the high morbidity, mortality, and cost. Now, given the poor diagnostic accuracy of individual diagnostic modalities, the voting panel voted for certain conditional recommendations. So, conditional recommendation is for pulmonary function test over a clinical history or a physical exam, as I mentioned. The conditional recommendation is against a 6-minute walk distance over the history of physical exam. Conditionally, they recommend against chest radiography over history and physical exam alone. Conditionally, they recommend against ambulatory desaturation testing. So you need to do a pulmonary function. You can't just get away with a desaturation testing. They conditionally recommend an HRCT over chest x-ray. We know HRCT, the acquisition, the slide reconstruction thickness is less than 1.5 mm versus a standard CT of 3 to 5 mm. And so it's really important to ask for an HRCT. And when we're talking about HRCT, we will talk about it later, where it's important to ask for inspiratory and expiratory images, which is inspiratory prone images to differentiate dependent lung atelectasis and early fibrosis, and supine and expiratory images to assess air trapping. That's very, very important. They also conditionally recommend doing PFTs over the desaturation testing and HRCT over PFT alone. And they recommend HRCT plus PFT over PFT alone, no bronchoscopy, and strongly against. So, this is the only strong recommendation from the list against surgical lung biopsy for screening. So, one has to be very cautious about what we are using as a screening tool for these patients. So, why not just PFTs? It's important to understand that pulmonary function testing can stay normal despite the presence of an interstitial lung disease. And if you are using a relative drop in the forced vital capacity less than 80%, then the sensitivity of this to detect an ILD is only 47.5%, which means that a patient might drop from a supernormal earlier, say 115 at baseline, and now he may be 85. He's lost a considerable amount of lung volume, of capacity, but the test is reading 85 as normal. So you cannot use just a pulmonary function test. There's also low certainty evidence from at least 5 observational studies which says PFT alone is insufficient to detect ILD in newly diagnosed SARD. And if you're talking about FVC less than 80%, the specificity is only around 78%. Whereas an HRCT has a sensitivity of 100% and a specificity of 55%. So, what do we do best? We combine both. We do a comprehensive screening and we use them in tandem. So, then why HRCT? We know the high resolution cuts are giving us a sensitivity of around 100%. And we know that patients who are undergoing HRCT, the radiation exposure is not much. The amount of exposure is low. The risk of radiation induced malignancies per scan basis is low. So, this low risk and extrapolation of the benefit of doing an HRCT together makes it a very, very strong tool. So, HRCT and PFTs can give you a complementary information about the ILD pattern and the physiological impact. So, the combination is way, way better. Moreover, an HRCT can help you detect other issues such as dilatation of the pulmonary trunk. It can also pinpoint bronchial disorders or small airway involvement and can go a long way over doing a chest x ray alone. The panel classically says do not just do an X ray, do not use just a 6-minute walk distance as a primary screening tool because joint limitations may exist. And an X ray is only around 64% sensitive. So it will lack that resolution that you will need to see early stage fibrotic reticulations or ground glasses. Again, surgical lung biopsy is a strict, strong no for screening because of the high requirement of hospitalization, a general anesthesia, and a mortality risk. Now, once you've diagnosed this ILD, they've also given us what to do for monitoring. So the focus shifts to tracking progression. What tools would you use? Again, pulmonary function test and HRCT. They will still, when clinically indicated though, be our primary monitoring tool. Now, would you use desaturation testing? So, there is a conditional recommendation for monitoring to know the need of supplemental oxygen by making the patient walk. So, an ambulatory desaturation testing. Now here, when we talk about the monitoring tools, these three are most important. So here again, the conditional recommendation says that when you are using these tools for monitoring, then pulmonary function tests are better than just doing a history and exam. They conditionally say an HRCT for monitoring is better. They say that don't use 6-minute walk test over a history and physical exam alone. They conditionally recommend against an X-ray over history physical exam alone. Now here they conditionally recommend you can do an ambulatory desaturation testing over a physical exam alone. You can also, they recommend do an HRCT over a bronchoscopy, but they conditionally recommend against a bronchoscopy for just monitoring. So when it's indicated, when you suspect there is a new onset infection or worsening and it's indicated, then they recommend that you should do an HRCT chest first and see the patient and not go ahead and do a bronchoscopy for monitoring right away. They recommend pulmonary function tests over 6-minute walk distance. And again, they recommend do both pulmonary function test and HRCT over pulmonary function testing alone. So this is the screening and monitoring summary flowchart given in this paper. The basis, the key concept is do PFT plus HRCT. So if there is a person with SARD of interest, he's at increased risk of ILD based on our risk factors, then we do both pulmonary function and HRCT. And pulmonary function means the detailed pulmonary function with spirometry, lung volume, and diffusion as a screening test. If you diagnose the ILD, For monitoring, you do a pulmonary function, you do ambulatory desaturation testing, and you an HRCT chest. How, what frequency, we're going to talk about in the next image. So the monitoring frequency is ideally, a bottom line is 3 months, 3 months to 6 months, or if the disease is quite stable, 3 to 12 months. So the best way is that just like the patient is visiting the rheumatologist in 3 months, he can also visit the pulmonologist for monitoring. So again, depending on disease to disease, this frequency can change. For diseases like systemic sclerosis and inflammatory myopathies, the risk of interstitial lung disease is much, much higher compared to other SARDs of interest. So here the patient must undergo a pulmonary function every 3 to 6 months for the initial year. And remember, what did we say? The screening in the first 5 to 7 years must be there. So this initial year, and once he's stable and we haven't detected it, the frequency can be reduced. For rheumatoid arthritis, Sjogren's disease, and mixed connective tissue disease, the pulmonary function test must be done again every 3 to 12 months for the first year. So it's important to do a pulmonary function test with your visit. And for monitoring, an ambulatory desaturation can be tested every 3 to 12 months. They haven't mentioned HRCT here because that will be used when clinically indicated. So, when do we use HRCT in monitoring? When the symptoms worsen. When we expect a coexisting morbidity, say a new onset infection, a pneumonia, a nodule which was detected incidentally, or a worsening in the form of increase in fibrosis with progressive testing. So that is when an HRCT will be used whenever indicated for monitoring. You will not use an X-ray for monitoring because it will give you very less information. You will not use only a 6-minute walk distance for monitoring. But if you are combining it with a continuous ambulatory desaturation testing for that time, it may be of use. And you will not, definitely not use a bronchoscopy for monitoring. Now, here there are few practical considerations given in this paper. They say it's important to have a collaborative care, so a good MDT between a rheumatologist and a pulmonologist. They say that in these diseases, we have to be careful about certain physical barriers, such as a patient with microstomia in systemic sclerosis may not be able to use a mouthpiece well for a pulmonary function. We have to adjust around it, probably give them pediatric mouthpieces, because otherwise the pulmonary function test will not be a correct test. There'll be a lot of leakage. If you're not able to measure the saturation because of poor signal, for instance, in patients with Raynaud's, you may use a ear or a forehead sensor. So we have to be careful about what disease we are dealing with. If there's a joint deformity, it may be difficult to put a probe for SpO2 monitoring. So that is important, and it's important to understand a patient's own perspective. Patients will always prefer to have an early screening and a frequent monitoring for stability. So we should not deprive them of that preference. So that's important when we are discussing about HRCTs and repeated PFTs with these patients. With that, let's summarize the screening and the monitoring recommendations. It's important to remember we need the right patient for the right test and the right time. Do you use chest radiography, 6-minute walk, ambulatory desaturation testing, bronchoscopy, or surgical lung biopsy for screening? No. When do we use ambulatory desaturation testing? You can use it initially if your pulmonary function test was not possible, or You can use a bronchoscopy initially if you were suspecting something else, say a malignancy which you had to sample, or an infection or an alveolar hemorrhage in such a patient, but not to screen an ILD. When do we use our ambulatory desaturation testing? For monitoring. When can we use the 6-minute walk test? When your patient cannot perform a PFT, or when a patient is undergoing transplant, it may be a part of the whole algorithm. We do not use a chest x ray routinely for monitoring unless you were suspecting an infection and you wanted to look out for that. And you do not use a bronchoscopy just for monitoring unless it's indicated. The gold standard is pulmonary function test plus HRCT for screening, and pulmonary function test and desaturation testing for monitoring with or without an HRCT. So with that, we conclude this video on screening for ILD in patients with SARD. See you again with another video. Stay tuned, subscribe, like, and share Pulmonology Read Aloud with your friends and colleagues. Thank you and bye.